I'm Dr. Mandeep Mehra from Mass General Brigham here in Boston, Massachusetts, bringing you Heart Failure Minutes. I'm very pleased to introduce Dr. Milica Vukićević, who is a Harvey scholar, and Dr. Ameesh Isath, an advanced heart failure specialist within the Mass General Brigham Heart Failure Program. We're going to discuss the recent paper that highlights a very interesting component of hydroxychloroquine cardiotoxicity that is less well understood and appreciated, that of progressive conduction system disease in this syndrome. Welcome, Milica and Ameesh. Well, the expanding use of hydroxychloroquine for systemic autoimmune and inflammatory diseases has heightened the importance of recognizing its cardiotoxic potential. While myocardial manifestations are generally understood to be the primary form of cardiac toxicity in the form of restrictive or hypertrophic cardiomyopathy, we think that progressive conduction system disease remains largely ignored. Milica and Ameesh, you have just reported on a 67-year-old woman who had rheumatoid arthritis, and she was receiving long-term hydroxychloroquine and presented with progressive conduction system abnormalities culminating in cardiogenic shock. She had an initial period of recovery, evidence of biopsy-proven cardiotoxicity from hydroxychloroquine, but then died despite an initial stabilization period and the use of isolated atrial pacing. I would like our viewers to understand some critical components and nuances that they need to keep in mind as they manage such patients to avert this abrupt and unexpected fatal outcome. So, Milica, I'd like to start with you. Tell us a bit about the specific property of hydroxychloroquine that accounts for its cardiotoxicity.
HCQ accumulates in lysosomes through ion trapping, and this lysosomal tropism underlies both its therapeutic and toxic effects. Sustained tissue accumulation with a prolonged elimination half-life, 40 to 50 days, results in vacuolization in lamellar or curvilinear inclusions and impaired autophagy. In the heart, these processes affect both myocardium and conduction tissue. Thus, the primary presentation is that of a restrictive or hypertrophic myopathy due to infiltration and scarring. But importantly, this is not restricted just to the myocardium, but also extends to conduction system tissue as well.
Yeah. Very, very important statement. We often ignore that. So, Ameesh, what are the specific risk factors that determine hydroxychloroquine toxicity, and how long does it take to see an improvement? Let's say you stop the drug. Is it immediate? What happens?
So the risk factors include long duration of treatment, more than 5 years, a high cumulative dose of more than 500 grams, kidney dysfunction, older age, as well as female sex. And in lupus cohorts, abnormal troponin and BNP levels have identified subclinical toxicity in about 10% of these patients. And of these, 1/3 ultimately confirmed to have plaquenil cardiotoxicity. Something less well known is that the drug has a half-life of 40 to 50 days, and thus one may not see recovery early after removal of the drug exposure.
Very important point. So, Milica, the paper suggests that this patient presented with a left bundle branch block and sinus nodal disease that required initial atrial pacing, and she responded to this with transient benefit. Yet the patient then developed progressive heart block even after days of cessation of hydroxychloroquine during hospitalization. At that point of time, she was unable to be resuscitated because of neurological complications from hypoxic brain injury. How should clinicians think about this complication of hydroxychloroquine toxicity?
Cardiac biopsy does not typically include the conduction system, and even cardiac MRI does not reliably detect conduction system involvement. Actually, progressive ECG changes are often the earliest and sometimes the only clue, even before myocardial disease is actually visible. So we have shown in our case that the first evidence of conduction system fibrosis, which we believe is irresistible, perhaps due to the high density of lysosomes in such tissue that suffer destruction. We were unable to find any cases where AV conduction recovery have been reported. However, we did find a substantial number of cases where patients are discharged home and died of sudden death, which could be quite preventable with dual chamber pacing. One such evidence of high-grade conduction system disease is detected.
Yeah, you may have just highlighted one of the most profound and important clinical implications of hydroxychloroquine toxicity. So, Ameesh, turning to you, is this finding unique only to hydroxychloroquine toxicity, or are there other lysosomal disorders such as, say, Fabry's disease or LAMP2 related mutation disease? What's the core message that a clinician should learn from this case?
Yes, you're right. So similar mechanisms exist in lysosomal storage disorders such as Danon disease or Fabry's disease even, where it is known that conduction abnormalities progress irreversibly despite myocardial recovery in response to therapy, and a sudden death may occur. So conduction disturbances including AV block, bundle branch block, and sinus node dysfunction have been reported in about 85% of patients with plaquenil cardiotoxicity, underscoring the central role in their pathophysiology. The important clinical point is that the presence of conduction system abnormalities should be looked for proactively, including using Holter monitoring, and intervention with pacemakers, when found, should be used to avert fatal outcomes.
Yeah, so a call for heightened vigilance in this disorder. So the key points that we have learned today from this case is that we must look for hydroxychloroquine toxicity in individuals at high risk. A prospective search for conduction system involvement should be done, perhaps even with Holter monitor testing or other mechanisms. That a potential adverse negative and fatal outcome may be easily prevented or averted with something as easily available as a dual-chambered pacemaker. And one of the things you have highlighted is that atrial pacing alone might not work because this disease is progressive across the AV node. Thanks, Milica and Ameesh, for this incredibly interesting case. This is Mandeep Mehra signing off. Until next time.